Hello, Dr. Dark. I can't understand mechanical intestinal obstruction. Can you tell me how can I diagnose and treat this case? Of course. Intestinal obstruction may be mechanical or paralytic in nature. There are many causes of mechanical intestinal obstruction, including adhesions, which is most common cause. Also include obstructed hernia, which is commonly inguinal, femoral, paraumbilical, incisional, and rarely, obturator, spigelian, or lumbar. I know that tumors can cause intestinal obstruction, is that right? Yeah, especially sigmoid colon tumor. Also gastric tumor can cause it. But it's a rare event. There are some other causes. For example, intussusception, volvulus, inflammatory mass such as Crohn's disease. Also gallstone ileus, pelvic kidney and peptic ulcer disease can cause mechanical intestinal obstruction. So, what is the classic symptoms of intestinal obstruction? I know that the exact presentation depends on the site of obstruction and the underlying cause, but can you give me an example about this point? Classic symptoms are abdominal pain, distension, vomiting, and constipation. But to answer your question, I will give you an example. For example, a history of severe pain suggests strangulation and developing ischemia in a closed loop. Also, the nature of the vomit may give a clue to the site of obstruction. So, I should ask about previous surgery when I take a history from patient. Yeah, of course, especially in cases of severe pain. But what are the main points in examination of this patient? Firstly, look for evidence of dehydration or shock. Then carefully examine the hernial orifices, because an obstructed femoral hernia is otherwise easily missed. Inspect for scars from old surgery. Note any distension and areas of tenderness. Bowel sound may be tinkling or absent. Also, PR examination may reveal an empty rectum. What about investigations? Request chest and supine abdominal x-rays. If there is no convincing evidence of obstruction on the supine view, but still a high index of clinical suspicion, consider requesting a CT scan. X-rays may demonstrate distended loops of bowel with multiple fluid levels visible on an erect abdominal view. The site and nature of distended bowel loops may suggest the site of obstruction. Small bowel obstruction results in dilated loops of bowel with valvulae conniventes completely traversing the lumen, whereas large bowel haustra do not completely cross the lumen. But I want to ask you a question. What is the diagnostic investigation in gallstone ileus? I think X-ray. Is that true? Yeah, although gallstone ileus is rare, X-rays may be diagnostic. Because the fistula between the bowel and the gallbladder allows gas into the biliary tree, which shows up as an abnormal Y-shaped gas shadow in the red hypochondrium. Also consider EBG if the patient is sucked. Okay, doctor, but how can I manage this case as a GP? Insert an IV cannula and start IV of 0.9% saline. If the patient is shocked, resuscitate with O2 and IV fluids and insert a urinary catheter. Consider the need to insert a central venous line to guide resuscitation and involve ICU specialists at an early stage. Provide analgesia. Give an antiemetic, for example cyclizine 50 mg. Insert an NG tube. Then refer to the surgical team for ongoing care. Thank you, doctor.